Thank you so much. My name is Neena Vijayvergia, and I'm here to talk about NET testing. I just want to thank the LACNETS team and Lisa for inviting me to give a talk on this important topic. We're going to talk about everything from what, when, how, and why of the NET testing. So why is it important? I know this is an obligatory slide that we use all the time. Neuroendocrine tumors are increasing. There is definitely up to a 7-fold increase in the incidence of these tumors. Is it because they're actually increasing, or we're just getting better at NET testing? It's still to be determined, but we're definitely diagnosing more of these, and hence we need to make sure we are up to date and also working to improve these testing techniques even more. Most of the neuroendocrine tumors are sporadic. About 10% of them are hereditary, and they're associated with syndromes like the MEN1, VHL, tuberous sclerosis, and neurofibromatosis. But definitely there is special testing for them, genetic screening, counseling that is required. And when your physician sees you, they talk about your family history, and if there's any concern, the referral happens and testing occurs for that. Presentation for neuroendocrine tumors can be a myriad of ways. You could be completely asymptomatic, like pretty much half of the patients who come and see me, they have ER visit for something completely different, or they had a colonoscopy or a CT of the chest for something completely different, and then were found to have a tumor that was there in the lung or in the rectum or in the colon or liver lesions or something like that, which led to the diagnosis of their tumor. So a good chunk of the patients are asymptomatic. There's a group of patients who develop something called the carcinoid syndrome, about 30 to 40% of midgut NETs, for example. And these patients present with the diarrhea, the flushing, the typical symptoms that we talk about. Some patients present with some hormone-related symptoms that are other than carcinoid. So a pancreatic neuroendocrine tumor patient can present with low blood sugars because they have an insulinoma. Or I recently had a patient with extremely high blood sugar levels because it was a glucagonoma, or secreting the hormone that increases your blood sugar. And there's a small group of patients, and these are more of the higher grade tumors that actually present with tumor-related symptoms, like the tumors growing and causing pressure on the surrounding organs, or pain and other issues. But that is definitely a few of our patients present that way too. So because of these different presentations, the testing for these tumors is in different ways. Carcinoid syndrome is probably one of the most common symptoms that initiates testing, like preemptive testing for neuroendocrine tumors. When the tumors, we think they go to the liver, and then the hormone produced can actually enter your systemic circulation, which means it actually is able to get access to your bloodstream. Then you start getting symptoms of it. And there are so many different kinds of hormones that they produce, like the symptoms, what you get are totally dependent on that. And this is just a good example of the different hormones that lead to the different symptoms. Is it flushing, which is the most common symptom? Is it dilated skin veins and bluish discoloration of the fingertips, which could be from the kinins, histamines? In the diarrhea cramps, which is the serotonin? The heart problems, which is also the serotonin? And sometimes wheezing, which can come from the kinins. Rarely, it can cause some cognitive effects, muscle weakness, and hives. And the hormone that's released basically decides what symptom you'll have. So a group of patients also develop not carcinoid syndrome in general, but symptoms because of whatever hormone they're producing. I have a patient who's producing extra parathyroid hormone or related peptide or similar to parathyroid hormone, and their calcium is up. Or I have a patient who's an insulinoma, and their insulin levels up and their sugars are really low. So these are the different symptoms that they present with. And it's important to know that symptoms because that is a very important part of NET testing. As you can see on this slide, neuroendocrine tumors patients do not present very straightforward. It's not like you go to the doctor and there'll be neuroendocrine tumor or neuroendocrine neoplasm written on the face or with what we're testing. I wish it was as easy as diagnosing this schwannoma, but unfortunately it is not. And when we talk about the treatment, the clinical history is the key, is the most important NET test that we can think of. The patients have such different symptoms that we could think the patients develop a lot of myriad symptoms, and the hormones you check and the blood test you do or the imaging you do is very dependent on what the symptoms the patient present with. So just sitting with the patient and I love doing that, talking to the patients and really understanding what their symptoms are has helped me immensely to identify the right test to order for them. So apart from the clinical history, which is the most important NET test, I feel, is there are other tests that are biochemical, how we confirm our clinical suspicions. Biochemical testing, which is basically blood or urine, you look chemicals in the blood and urine. And the one that I like the most for patients who have symptoms is urine 5-HIAA. It is collected over a 24-hour period. It's a very cumbersome test, right? I agree with that. But it actually, if someone is suspected to have a carcinoid syndrome, it has a 90% accuracy, nearly, to identify if the serotonin is causing their diarrhea. You always have to avoid a long list of foods around that, including coffee, which is very hard to do. But in general, if you can do the test accurately, it's a very good test. Normally it's not elevated in other conditions. It's very much more accurate for the midgut carcinoids. Unfortunately, even though urine 5-HI is the most accurate one, because of how cumbersome it is and the fact that we cannot just draw it from the blood, it's not very commonly used. The most commonly used one is actually this test called the chromogranin A, which your primary care doctor can order, your GI doctor can order, or anybody actually, most people can order it easily. The problem with this test is it has very poor accuracy, right? In patients who have neuroendocrine tumors, the sensitivity of this test ranges from 50 to 80% in different studies. And I actually once read a study, and I could never find it again, so I haven't put it up here, but there was a study where they checked chromogranin levels in normal people, and then another in people who had neuroendocrine tumors, and the average level of the test was actually higher in normal people than it was in neuroendocrine tumor patients. And so that's why it's just such an inaccurate test that even the guidelines nowadays are recommending not using it as a good screening test. Then you have serotonin, which is a blood-based test for a chemical that is produced by neuroendocrine tumor cells, but can also be produced by a lot of normal cells, more importantly, the platelets. Platelets are cells that run in your bloodstream that prevent bleeding, and they can produce serotonin if they're activated, and sometimes the levels in the blood could be elevated just because of that. That's why there's more investigation around plasma serotonin or plasma 5-HIAA levels, which is much more accurate, but it's still investigational and not easily available, but I think would be a test for the future. Apart from these chemical testing, a lot of us do, anatomic or functional imaging, which basically means doing some sort of a scan to look at if there is a tumor, is there a source of these hormones being produced. You do CAT scans and MRIs. We do endoscopic interventions. That's something we do too. And then lastly, one of the newer things that have come is functional imaging for these tumors. All neuroendocrine tumors, or most of them, have this special receptor on their surface called the somatostatin receptor. So basically, think of it as a protein, and we have made a drug that goes and binds to it and a lock and key mechanism. So if you attach a radiolabeled dye, it's going to go to the tumor and light it up. So it's very easy to see that way, but even that technique has improved over time from a test called octreotide scan a long time ago to the more recent ones like the gallium and copper scans, which are the PET scans. Now, this is a very good figure depicting what the different blood-based tests are for neuroendocrine tumors and how we actually look at them. So at the bottom of the figure, there's this neuroendocrine tumor cells. It produces all these hormones, as you can see, which are these yellow and the green things, and also the red ones. And then also the cancer cells have their genome or the DNA in that, which gets converted into RNA, and also just fragments of this DNA, they are released into the bloodstream. So when you're looking at a blood test, you can detect these hormones. You can detect some special proteins or peptides is how we call that, which these tumors secrete. Or you can just look at degraded RNA or DNA from these tumors in the bloodstream, including circulating tumor cells. So the peptide hormones that we look for include chromogranin, there's pancreatic polypeptide, VIP, insulin, glucagon, gastrin, and a ton of others. There's amines, or these are basically the serotonin and the 5-HIAA that you can see here. And there are some other proteins too that are being investigated that these tumors secrete. And then the genetic material that comes out of the cancer cells and in the bloodstream is also being used to evaluate if we can use that for diagnosis and treatment. So I've talked a lot about the different tests. Again, these are all the different tests that are done. There's blood-based tests, there's imaging tests, there's urine tests. We talked about chromogranin A. Again, it's a test that's unfortunately very commonly used, but it's not the best test for screening. I think the utility of chromogranin A to me is mostly when I have a patient with a known diagnosis and they secrete this hormone, I can maybe follow it and help me guide if I need to do a scan sooner or later, things like that. But other than that, I think the utility of this test is going down. There's, also if you have kidney failure or liver failure, or if you're using a proton pump inhibitor, which is antacid drugs, and then also other malignancies can all raise the chromogranin A level, which makes it a less sensitive test. The other is pancreastatin, which is a little more reliable than chromogranin. It's just a subunit of the chromogranin A test. The problem with this test is it has not been widely studied in neuroendocrine tumors. So you get a result, you're not exactly sure what to make of it, but it is, if you have to choose and if you have the ability to do it, it can be done slightly better than chromogranin A, I feel. Its utility also in screening has never been studied. Then you have the pancreatic polypeptide. Now, this is more expressed in the pancreatic neuroendocrine tumors, as indicated by its name. But again, its utility for screening and for just for evaluation of therapy has never been tested very widely. So we don't know what it really means if the number goes up or down. So hence, it's not used that often. And then the more recent one, or the new kid on the block that I just want to talk to you a little bit about more later, is this new test called the NET test. It's just more expensive because it's a more novel kind of test. In imaging, you talk about the CAT scans and the MRIs. They're very, they have great availability. You can get it done anywhere, low to intermediate cost. So that's the benefit of it. And it remains sort of in some way a gold standard because you can actually see the anatomy. You can know what you can biopsy from it. Then there's this functional imaging with the gallium-68 or the copper-64 PET scans. These are very extensively studied. They always perform excellently. We're going to see that in a minute, and you have a full talk on this later on, so I'm not going to belabor it for you. But you always have to remember everything has false positives, which could be inflammation, lymphoma, meningioma, kidney cancer, and some physiological uptake in various places. So whenever you get results, you always have to discuss with your provider who's educated and is also experienced in taking care of neuroendocrine tumors, so as to tease out what is real versus not, because there's no test is 100%. In urine, the 24-hour 5-HIAA is the most sensitive and specific test if you're worried about carcinoid syndrome, and especially if it's for midgut nets, which produce the serotonin hormone, and is something that I use very often for screening and should be used way more for screening in the community. It is unfortunately a very cumbersome test. So, 24 hours collecting urine, keeping it in your refrigerator for one full day is not easy, and I get it. But that is a very sensitive test. So now let's move on to the next part. I told you I'm going to talk to you a little bit about this new test called the NET test. It's a new kid on the block. Basically, it's they were looking at, remember I showed you the NET cell and produces the genetic material in the bloodstream. So they basically are taking up that genetic material from the bloodstream. So it's just a blood test. They take the cancer-related genetic material from that, and then they test it and they look for these 51 marker genes in it, which is like through a very specific algorithm of their own, which we don't need to go into. And then you get results in two ways. One is positive or not. So you can have a normal test as indicated by the green line here, or you could have a negative test, which is the normal portion, and the positive test is above that. And then also, once you do that, you also get a score from it, which is the NET test score, which is a risk index. And what they use this is for if you have a higher risk NET score, that means that you have a higher risk of the cancer progressing. So this comes in more than 80%. 41 to 80 is intermediate, and less than 40 is low risk. So these are the two results you get from this test. It has applications that can be thought of, for diagnosis. Obviously, if you plus or minus, if you have a better test, can be used for monitoring. If someone's on wait and watch approach, and which means you're not actually treating the cancer, you're just watching it. You can follow this and see if you have a low risk versus a high risk on this test. Could you just wait more comfortably than to treat somebody? And then there's a lot of work being done to show if it can be a marker of early response to some novel therapies, like the peptide receptor radionuclide therapy, which is the 177 lutetium dotatate therapy. Now, these are some of the tests that are done to evaluate that. So, the first test is basically they tested 100 patients with neuroendocrine tumors, which were proven with imaging, and they did NET test and CG and chromogranin A on them. All of those patients, 96% of the patient who had a tumor had the NET test positive. So that's a good number. And then all the patients who had both NET test and the CGA or the chromogranin A, all of them had NET test that was elevated, but only 25% of them actually had their chromogranin A elevated. So telling you that chromogranin A is not the best test. The same thing you see on the right side, there's different types of location. First is small bowel, second set is pancreas, the third is bronchopulmonary. And across the board, the NET test performs much better than the chromogranin A, and the numbers are in the 90% range for all of them. If you also look at, this was the study that they looked at the cohort of patients, and there was a group of patients who were being watched and this group of patients who were being treated. Again, if based on the score, like the 40% versus the 80%, what we get the score, if you are low risk, you tend to have a much better outcome than if you're high risk. So you could think of it that if you are a low risk patient, you are much more comfortable going on wait and watch than if you're a high risk patient. But again, all of these are hypotheses that need to be further tested. So it is ordered, but it's not completely ready for prime time because all of this work has been done retrospectively. And there are a few prospective studies, but a large scale prospective studies need to be done so that we can incorporate it. The question, because it's not an easy test, it's a very expensive test. So we have to make sure we're doing it right when we do it. I'm going to finish it up with this last part, which is the imaging in NETs very quickly. I always say, let's detect the spot. That's the most important thing you need to do, whether you use the detect net or the net spot, but we have to detect the spot. The reason why we have gotten so much better at diagnosing neuroendocrine tumors is actually, advent of these gallium scans or the copper 64 PET scans. These are called somatostatin receptor imaging. And you can see previously we had something called the octreotide scan, which is on the left, compared to the more recent scan. The same patient, you can see how much more disease and how much more clarity in the tumors. All the black spots that you see here is the cancer spots. It is much more easily and much more clearly visible when you do the newer scan than the previous old octreotide scan. So these have pretty much replaced the management of our patients in the imaging world. And that's also indicated by their performances, their sensitivity, which means that if you have a disease, it will actually show it to you. The specificity, that it will only show the cancer and nothing else, and accuracy, which is a combination of both of these things. And all these indices are in the 90%, which are much poorer for the octreotide scan. So if your doctor orders an octreotide scan for you, please ask them to change it to the PET scans, because you don't want radiation for no reason. And the newer PET scans, the gallium and the copper, are so much better that we should not be ordering octreotide scans on people anymore if we can. So this is all about neuroendocrine tumor testing. It is very important. The most important thing for this testing is the step, once you know a problem, you look for it. So I want to, there are big celebrities who have unfortunately succumbed to this disease. I bring up two: Steve Jobs on the left and Irfan Khan. He was a very famous Bollywood actor. Both of them succumbed to pancreatic neuroendocrine tumors, unfortunately. But I think all of this has increased the awareness of the disease amongst patients who are the ultimate experts in this disease, and also helped the physicians know more about this disease. We have so many good testing opportunities that we need to do better at helping patients and not delaying the diagnosis by 5 to 8 years that used to be, and which is not appropriate. So thank you, everyone. It was a pleasure talking to you today. Happy to take any questions.